Hello everyone, in this video we are reviewing unstable angina and non-ST segment elevation myocardial infarction. In a scheme of things, if we see ischemic heart disease, this is the area we are reviewing today. And ischemic heart disease can be divided into coronary artery disease, which presents with stable angina, and into the acute coronary syndromes, of which unstable angina and NSTEMI is a part, and acute myocardial infarction is the other part, which is not part of this video. So to begin, we here will differentiate between what is stable angina and what is unstable angina. Stable angina would entail chest or arm discomfort or pain. Just increased with this is associated with increased physical exertion, and it is relieved in 5 to 10 minutes by either by rest or sublingual nitroglycerin. This is NTG, sublingual nitroglycerin. Let's move to unstable angina, the topic of this video. It is angina pectoris or equivalent ischemic discomfort with at least one of the following. You here should focus on this thing. It is angina pectoris with or equivalent ischemic discomfort with one of these following. Angina is described as a squeezing, pressuring type of a pain, as if something heavy is kept on a patient's chest, a heavy weight or something like that. So patient would complain of history. The patient will tell you that I'm feeling as if some heavy weight is on my chest. If that is there and it is associated with, it occurs at rest and usually lasts more than 10 minutes. It is severe and new onset, and it follows a crescendo pattern. It is more severe or it is more prolonged, and it is rather more frequent than before. So this is a progressive kind of a history where if you follow a patient, you might want to look into these things. And if you are taking a history from patient, you might want to look into things of a problem, a chest pain which is rising, which is increasing in frequency, which is more severe than before, and which is more prolonged in its duration. And this differentiates stable and unstable angina. The pathophysiology of unstable angina. The basic reason is decreased oxygen supply and increased myocardial oxygen demand. This is by far, if I can say, the central dogma in myocardial diseases, but still let's continue. But this is the specific thing which is there in unstable angina is the decreased oxygen supply and increased myocardial demand is more often superimposed on a lesion that causes coronary artery obstructions. We'll talk about it. Now, the processes that may contribute to the development of unstable angina oblique NSTEMI. The difference between this part, the NSTEMI and unstable angina, they are similar except for the fact that a person with non-ST segment elevation MI will have elevated levels of cardiac enzymes. A person without elevated level of cardiac enzyme, we would classify them as unstable angina, given the background of clinical history, of course. And it is not that they are completely absent in unstable angina. They might be present, but the cardiac markers are very, very tiny or very small in amount as compared to what it is in NSTEMI. Now, amongst these processes that may contribute to the development of NSTEMI or unstable angina are: first one is plaque rupture or erosion with a superimposed non-occlusive thrombosis. It's not thrombosis, it is thrombus. There's a typing mistake here, it is thrombus. What happens is NSTEMI occurs due to, in these cases, NSTEMI occurs due to downstream embolization of platelet aggregates. When a thrombus is formed, and because secondary to the thrombus formation, there is downstream embolization of platelet aggregates and atherosclerotic debris. This is the main reason for in this group of patients. the first one. There might be some patients with dynamic obstruction. This is a topic of a separate review. We will be doing it. Dynamic obstruction is seen in cases of coronary spasm, as seen in Prinzmetal's variant angina. We're talking about dynamic obstruction. It is seen in coronary spasm, as which is seen in Prinzmetal's variant angina. The third one would be progressive mechanical obstruction. This would be classically in rapidly advancing coronary atherosclerosis. This one, the progressive mechanical obstruction. Now the other causes may be tachycardia and anemia. As far as the medical research is concerned, anemia and tachycardia, first of all, they both are related. A patient who is anemic will be tachycardic for most of the times. Anemia is more often associated with sorry, we just lost it. Anemia is mostly associated with many cardiovascular diseases. This is a topic of active medical research. So these two can also exacerbate the conditions of unstable angina, because in anemia there is already increased demand of oxygen, because hemoglobin is very low. So even minimal exertion can precipitate the attacks of unstable angina. This condition. Let's move. The clinical presentation in cases of unstable angina or NSTEMI. As I've told earlier, the large NSTEMI will be having increased laboratory findings. In this NSTEMI would be increased cardiac enzymes, but they would be absent or in very small amount in unstable angina. Then let's focus on this particular slide. The clinical presentation, the hallmark is chest pain, which is substernal, reduced to back, left shoulder or left arm. Discomfort is severe enough to be described as a frank pain. If the patient has a large area of myocardial infarction or a large NSTEMI, physical findings may show diaphoresis, which is secondary hyperhidrosis. There will be a lot of sweating, pale and cool skin, sinus tachycardia, third or fourth heart sound, basal rales, and hypotension. It must be very clear that this patient in a majority of cases will be asymptomatic. They will not have these symptoms, what we are talking here. They might be completely asymptomatic. Now, as far as diagnosis of NSTEMI is concerned, we will focus on the four things. There must be clinical features of unstable angina, as we spoke earlier. There should be ECG changes, and there should be evidence of myocardial necrosis. But what that evidence is basically the cardiac enzymes. And we also employ stress testing for diagnosis of NSTEMI. We'll talk about it. Let's see, as far as ECG is concerned, in 30 to 50% of cases, there is ST segment depression or transient ST segment elevation or a T-wave depression. These things need to be focused on. This is present in 30 to 50% of cases. In patients with clinical features of unstable angina, the presence of new ST segment deviation of only 0.05 millivolt is important predictor of adverse outcome. More important than that is the following fact, that T-wave changes are more sensitive to ischemia, but they are less specific unless they are fresh changes. So what it means is, if you see fresh T-wave changes of greater than or equal to 0.03 millivolt in a known patient of unstable angina, that should raise alarms. This is the employability of ECG in diagnosis of NSTEMI. Now let's come to cardiac biomarkers. The patients with unstable angina or NSTEMI who have presence of CKMB and troponin, they are at increased risk of death or recurrent MI. The increased troponin levels are directly proportional to mortality. However, we should keep in mind These are the conditions, that's congestive CHF, myocarditis, and pulmonary embolism. They will lead to minor elevation of troponins. This is this is just a general info in this background. Let's move ahead. Angioscopy is also done, and there are very contrasting findings in angioscopy as well. We to differentiate between NSTEMI and acute STEMI. In acute STEMI, what we see is a white thrombi, which is platelet rich. In NSTEMI, what we see is a red thrombi, which is fibrin rich. Now, what is this? What we do is, on angioscopy, we employ different kind of stains, and eosinophil blue stain is one of those stains. There are many other stains, and then those things are visualized. A thrombus is visualized after staining it. So the visualized thrombus appears to be white in acute STEMI, and it appears to be red in NSTEMI. This is a contrasting feature on angioscopy. We'll see this. Now here you can see angioscopic findings of thrombi in coronary lesions in patients with acute MI. The first one is red thrombus. This we're talking about this figure. It's a red thrombus. Second one is a mixed one, and third one is a white. So most likely you can see the white thrombi is case of ST segment elevation MI. This is most probably a case of NSTEMI, non-ST segment elevation MI. This is basically on angioscopy. We are staining the thrombus with dyes, and the color which comes out has contrasting features between NSTEMI and ST segment elevation MI. So this is ST segment elevation, this is non-ST segment elevation MI. At the end of this fast review, I would just like to revise a risk stratification. The individual who are at greater risk for unstable angina, oblique, NSTEMI. Age greater than 65 years, more than 3 risk factors for coronary artery disease, documented coronary artery disease at catheterization, which is coronary catheterization, development of NSTEMI or unstable angina while on aspirin. Yes, this is quite significant. If you are already on aspirin, still you're having the symptoms, the complaints, the development of maybe the clinical or the ECG or cardiac markers suggesting NSTEMI or unstable angina, this should raise alarm. This is a serious condition. More than 2 episodes of angina in last 24 hours, ST deviation greater than 0.05 millivolt, and presence of cardiac markers. The other risk factors here down below are diabetes mellitus, left ventricular dysfunction, renal dysfunction, and increased BNP and CRP. CRP is C-reactive protein, and BNP is brain natriuretic peptide. Thank you so much. This was the first review of unstable angina and NSTEMI. Kindly subscribe us for more such related videos where we'll be reviewing things in a similar manner. Thank you.